Hello, everyone, and thank you for joining the American Bifurcation Club Bifurcation Hour. This is an exciting evening today because we're going to go to Dr. Kwan Lee at the University of Arizona, Tucson, who will demonstrate a computer model of a simulated DK crush case. This will be moderated by Gautam Kumar, and Dr. Barbara Basir from Henry Ford and myself will interject as moderators as needed. So go ahead, let's get started.
Okay,
Kwan, go ahead. Introduce your team, please.
Yeah, Dr. Rab, thank you very much for this opportunity to be part of this. We are very excited today to be broadcasting to you from the University of Arizona on our Mentis G7 Plus platform, which allows you to do bifurcation simulation procedures. The menu of possible bifurcation techniques are DK crush, culotte, tap, mini crush. The module is very new. It was developed, and the clinical scenarios were developed in conjunction with Dr. Jens Larsen from the University of Copenhagen, who I think most of the world knows, who's part of the EBC, and Dr. Wolfram Volker from the University of Würzburg. He's a big name in the world of simulation, cardiology education, and myself here from the University of Arizona. So there's a little conflict of interest, I suppose. I do consult for Mentis in assisting them to develop this. I'm joined here with two of my colleagues here today who will assist in the case. I have Dr. J.R. Keng Pineda, who's one of my junior faculty member and associate director of our small simulation center here in Arizona. And I have Emily Sandrowski, who is a second-year fellow who's going to become one of our chief fellows and will be an interventional fellow at Mayo Rochester in the coming the year after this. We have prepared the case. We have pre-recorded some of the stuff so that we can jump ahead in the case because some of the stuff is just tedious and takes very long to get to. And we have Dr. Kumar will lead us through the slides, showing the case and discussing the issues. And then obviously we look forward to the input of the panelists as we move through. We're just excited to show the capability. This G7 Plus machine, which I'm going to move the camera over here, is the only commercial one available, purchased one in the United States right now at the teaching institution. It's very
so Kwan, you can show the machine a little bit. We are now on the shared screen with Gautam. Sure. Do you want Gautam to start? Then we'll come to you as soon as the slides are done. Then you can show us your machines and your staff members. Okay. Thank you.
Okay, perfect. So let me go ahead and get started. My name is Gautam Kumar from Emory. We're going to talk about and welcome to the ABC Bifurcation Hour. These are our disclosures. So this is the picture of the Vista G7 and G7 Plus that Dr. Lee is talking about. And does this picture, Dr. Lee, pretty much cover the same setup that you have there as well?
Fairly. The monitors that we got were obviously much larger. We have the G7 Plus unit, which is the unit on the lower end. As you can see on the top of the machine there, you can see that there's a bifurcation line. And this is I think probably close to the first time we've had such an advanced ability to put devices into the same sheath, right? Before some of the other bifurcation modules that you had to emulate digitally one of the balloons and one of the wires. The machine could not recognize two separate wires and two separate balloons, and the guide moving around with it as well. So this is the first time that there's a machine that can recognize all of these things moving at once, because you think about it as 5 moving parts.
Absolutely. Okay, so this is our case. We have a 67-year-old male who has been presenting with exertional angina for 6 weeks. Coronary artery disease risk factors include hypertension and hyperlipidemia. And nuclear exercise SPECT showed a 20% reversible defect in the anterolateral wall with EKG changes at low exercise levels and angina as well during the stress test. Okay, and this is our baseline angiogram. And you can see there's an angiogram which is done in an LAO view that basically shows the LAD diag bifurcation lesion. Contrast backfilling the circumflex backfilling the right and the circumflex actually show that there is not a whole lot of issues going on there. Vitals are stable currently with the aortic blood pressure of 118/70, heart rate of 60. Sats are also
So it sounds like Dr. Kumar's audio will wait for it to connect. So I suppose Dr. Rab.
at this point. They are set of wires, guide catheters, and balloons. So here, Dr. Lee has picked out two workhorse guide wires with a 45-degree bend and a 30-degree bend on it. And at this point, we're going to go ahead and wire both these vessels. And you can see Dr. Lee has wired both of these already.
Wait a second, Gautam.
And at this point, Dr. Rab or Dr. Basir, what would be your strategy for this?
Wait a second. Show us the previous screen where you had a menu of choices of wires to take. Is that part of the simulator as well?
Yes, correct. That is part of the simulator. You know, Dr. Kumar seems to be having some transmission problems. Are you hearing it at your end as well?
We are hearing all right. We're hearing it more clearly, Kwan. But okay, so you've chosen your wires. But
I can take over from the video if that helps.
Sure, go ahead.
Because Dr. Kumar seems to be cutting in and out. I'm sorry for that. And let me advance this along here.
You'll have to switch share screens then.
Yeah. So just out of curiosity here, you know, obviously there's a significant menu of different stenting options for us to choose from. You know, this is a Medina 111 LED diagonal. You know, the diagonal is fair size. It's a 2.5 millimeter, probably estimated looking at here, and the LED is probably 3.0 in the mid section onwards, and probably 3.5 approximately. That's my guess right now. And the angle is, you know, about 45 degrees. So it's less than 70 degrees. There doesn't seem to be any calcification. Dr. Rab, Dr. Basir, what are your what is your go-to stent strategy in this case?
Barbara, you want to start?
Yeah, I think, you know, so I personally, I still like to look at the side branch with imaging, just to make sure that we are really wanting to commit to bifurcation stents with the two-stent strategy as opposed to doing a provisional. But, you know, angiographically, I would probably, you know, use either a mini crush or a DK crush.
So you want a two-stent strategy, Barbara, is that correct? So,
yeah,
so if you take the European approach, you know, they would say, why don't you wire both and put the stent in size to this reality and do a right-sized pot, just crossing diagonal. And sometimes the diagonal starts looking better. And I've done that in my own practice. On the other hand, the lesion length is just at 5 millimeters. And the diagonal, it should be at least 10 millimeter with stenosis 70% to qualify for a second stent. So I could go either way. I could hedge and say, I'll do a provisional approach with pot and see what happens. And then if I have to put a second stent, then I could do a T with minimum protrusion, which is not the desired choice. But let's see what Kwan decided to do.
Yeah, okay. So, you know, just for some people would say maybe we should FFR both sides and see, but, you know, obviously the FFR pre-PCI is not extremely helpful because once you stent, you actually change, modify flow, etc. Yes, I totally agree with you. But in this setting, I think you know, we would like to do the DK crush just because we would like to show what the simulator has to offer, and it is the most complex of the upfront two-stent strategies. And therefore, from a training perspective, with a platform like this is probably the best application for simulation, procedural simulation, especially. You know, because it's not easy to learn DK crush. There's a tendency to forget some steps. You know, and if you miss a single step, you know, you can actually kind of mess up the procedure. And the true real-world uptake, despite the data to date, is not as high as we would like it to be, right? Most people still don't use the DK crush frequently. So this is a video here just showing you an example of exactly how objects are selected within the menu. Here we are pricking the first wire at 60 degrees, you know, it's an 014 wire. And you can see the two tracks up and down, the top and bottom part. And you can select different tools and different devices, each of these. And here I'm moving around, selecting the second wire for the upper and lower track. This is a video of us wiring both branches. You can see that despite the fact there are two wires within the sheath, the computer recognizes both wires independently. You know, we've obviously performed the first step, which is to wire both branches. We did bring an imaging catheter to the game. And so we have a simulation of an IVUS coming across, and it's based off the Eagle Eye Platinum volcano system. That's why it looks the way it does up here. And this is the IVUS run. It doesn't, you know, it's fair, the modeling. As you can imagine, these things are very complex to do. So, you know, we're not 100% real world, but I think this is a very good approximation as is. So in anticipation of complex upfront strategy, my preference is always to image if you can help it. I know there's a tendency sometimes to want to just jump the step. I don't think that's wise. And whenever I'm doing upfront two-stent strategy, I always image. Do you feel the same, Dr. Rab, Dr. Basir?
Yeah, I don't disagree with that, actually.
Yeah, so here we're just measuring. Okay, this is us measuring just to be sure. And we have close to 2.8 millimeters for the LAD distal to the lesion. And so I think 3 millimeter stent should be good. You know, the EL is definitely a bit larger than that. And then I'm pulling back into the proximal LAD to get our pot sizing right. And the pot size on this side, here we're gonna select our thing, jumping across. And it looks like we're close to 3.7, 3.5, probably about there. We then did the same thing for the first diagonal, just to get that right. And it was, I'll skip showing you that part, but we got 2.5 millimeters as a reference for the diagonal side branch.
Okay, I'm back. Sorry, lost internet.
Yeah, this is a video for the first stent deployment. So here we are, we've positioned the stent in the diagonal, and we're a 2.5 by 15 millimeter. We've deployed that, and then we're going to jump across here, and we are positioning, and we're sliding, obviously, the stent equipment back. I think some people...
Go on, one thing, so to remind everybody, there's a balloon across the origin of the diagonal. And one thing a lot of people do is when you pull the balloon back into the main vessel, you do a little high pressure dilatation for proximal stent optimization. So that's an important part of the stent deployment before you crush it.
So that raises an interesting point, Dr. Rab. Would you size the balloon in the LAD to the distal vessel, or would you size it to the proximal vessel and just do a pot alone with even that balloon itself? What are your thoughts there?
So a couple of things. The current thinking is that, first of all, when you withdraw the diagonal balloon, just go to a little higher pressure of the origin to really dilate the stress of the origin. And now, in terms of balloon across, I've personally not tried to oversize in the LAD balloon because I could cause a dissection distally. Now, in the left main is a little different. With the left main is the shorter length vessel is a larger in caliber, so you could go up with a larger size pot balloon in that setting. So a lot of that work in taking the largest balloon was to optimize the crush of the circumflex ostium. I'm not sure there's enough data about the diagonal branch though, okay, or the LAD diagonal.
Yeah, one variant we've seen as well. So in this variant, we decided to size to the LAD distal to the diagonal origin, and we inflated here to 12, 14, 15 atmospheres with the 3.0 non-compliant balloon. I've seen other variants where they just size the proximal, they don't cross over to the distal to avoid dissecting distal to that, and just literally perform a pot at this point prior to recrossing back. And obviously,
my concern about that is I'm not quite sure that the balloon covers all the way to the opposite wall of the diagonal. You know.
Yeah.
Crush may have been completed. Barbara, do you have any comments on that? Do you oversize?
No, I try to stay 1-to-1.
Okay, all right.
Okay. 1-to-1 to the distal LAD or 1-to-1 to the proximal LAD in this case?
No, so I get both the distal reference, the reference at the bifurcation for my pot, and then the most proximal reference.
Got you.
Yeah. Interestingly, within the EBC guidance of the simulation module here that Dr. Lassen developed, their recommendation was to do a size to the proximal and just pot it and then recross into that as your first cross. That's another variation. And obviously there's a large debate as well as whether you leave your wire while all this is happening or you pull out the wire. Here we decided to pull out the wire before we do this. All right, I'm gonna jump over there, okay? And so here I'm actually, and some people will even do this, right? They will pot at this point having size for the section distal to that, and then they will pot again. And this is clearly a variant that not everybody does and was never described in the original DK crush technique either. But I like it because then it definitely gets your stent absolutely up against the far wall.
Actually, the original DK crush description did not have any pot in it.
Yeah, that's right. No pots.
So, Kwan, one other thing, you measured the diameter 3.75, and we do have 375 balloons available, okay? In the market. Yes. So why didn't you use a 375?
I suppose I was trying to be slightly a bit more conservative. It's a good question. So, you know, I think in my lab, surprisingly, we actually don't have 375. I think we go 3540. So, you know, but obviously if you have 375, you probably should go 375. And this is us recrossing again. And I think the important point for the audience is that when you recross a DK crush, it's the only two-step bifurcation technique where you should cross in the proximal cell strut, not the distal cell strut, right?
So how can you, so what do you do to make sure that occurs, you know?
Yeah, that's a great question. You know, there are some heavy Asian guys who always OCT at this point to see exactly where your wire is. I think most of us will, you know, kind of say, all right, that looks like it's proximal. I don't know, maybe being a bit lazy on our side. Dr. Rab, what do you normally do to?
First of all, I magnify the image, and if you have stent boost available, for example,
yeah,
it can help you. Yeah. The thing is, if you're away from the carina, you know, you're pretty proximal. That's in my mind, okay?
Okay, now I'm going to walk over, because we have the case prepped up to this point. I'm going to walk over, ready for the first kiss. I'm going to walk over to the simulator now and turn that on. Okay, so I'm going to be moving over here. Okay, so here we are. And then also there's some variation here in how people do kissing balloons at this juncture. And you can see here that we have, hold on, let me put we have, the system allows you to recognize two separate inflated devices. One is here and one is here for each of the balloons, right? Okay, so that's diagonal and this is the thing. So, you know, there's lots of ways I've seen people do this. Some people just, A, in positioning of the balloon, first of all, and B, in the sequence of inflation. I like to do one high pressure, alternative high pressure, and then together up to mid pressure. Is that your preference too? Or? So we're going to go live here.
Babar, what do you do?
Yeah, I actually do the same thing.
Okay. I do the same. Gautam?
I generally just kiss at one pressure at this stage and just move on.
So this is me, 1 to 12. Okay, you can see that coming up. I'm going to come down. And then Dr. Pineda is going to go up. Obviously, the second balloon is a little deep, but in the interest of time here, that's not great technique. Okay, just ignore us right now. Yeah. Come down. Both our balloons are sliding forward a little bit, so we're going to withdraw them a little bit for the proper kiss, and then we're going to go up together. And this is a 3-0 and a 2-5 side.
Yeah, that looks like it's a good position there, Kwan.
Okay, yeah, we're both going up together now. We're both going to go up to 12. And then we're going to come down. Okay, come down.
And deflation should be simultaneous, okay?
Yeah, we are simultaneous. Yes, absolutely. The deflation needs to be simultaneous.
So one thing differently I inflate the diagonal side branch first to higher pressure.
Okay.
Like 16 or 18, then deflate it down to 12, then inflate up the LAD to maybe 16 or so, then go down to 12, and then no, I deflate the diagonal, then go up the LAD, go down to 16, go down to 12, to complete deflation, then pull it back like you just did, and then do it at about 10 to 12 atmospheres and pull them back together. Deflation, pull them back.
Right. And obviously at this point, we need to get ready for the main branch stenting. Do you want to leave the wire up? Should we?
No, you've got to pull this wire out.
You have to pull the wire now.
No, I agree. I totally agree. Although some people say that they leave the wire out at this junction too.
No, you cannot, because you'll be crushed by 2 layers of stents there.
Yes. No, that makes me extremely uncomfortable as well. So let's pick the LED. So Dr. Pineda is going to pick us a 3024. It's very important to have enough stent to be able to pot. It's sometimes some people forget that. Yeah, 23 or something. Okay.
So you don't want to be too short proximally either. I think that's an important factor.
Right.
You want to make sure you have enough stent that you can have in the proximal LAD so that you can have a successful pot.
So at least 8 millimeter. So take at least an 8 millimeter.
Yeah, 6
to 8 millimeter balloon is what
I'm going to test that. And just out of curiosity as well, the nice thing about simulation environments, you can actually do this. You can actually see the world in different modalities, which is something you cannot do in real life. Obviously there's some benefits of simulation, and then some things that are not as real as we still hope them to be, despite all of the advancements we've made. But this is one of the strengths, I think. So here I am. I'm going to deploy my 3023 stent, and here we're coming up. Okay, so we've done that. Pushing down, coming across 12 atmospheres. Okay, and I'm coming down. So that's imaging here.
And if you look at the AV there, you can actually see that the diag stent has been nicely crushed. You can look at it and it actually looks like it is crushed.
Yeah.
So that's a very nice simulation of the audiovisual there.
Yeah. And at this juncture, we're going to do a pot, right? Maybe a 3512. A 375. Let's do what Dr. Rab suggested for us earlier.
375 by 8.
Yeah, let's try it. See what
375 by 8.
Oh, the simulator is also like my cath lab. No 375. So we're going to go with 358. Yeah, 358. Yeah. Okay. COVID, the fiscal crisis of COVID. One of the things that, that's happening in this simulation as well is it's quite easy to cross the struts. Obviously, that's a very hard thing to build into a simulation model. Are you guys happy with that position?
I would come back a tiny bit.
Yeah, you're not reaching the carina. Yeah. But Barbara, what do you think?
Like here?
Yeah, I liked for the proximal balloon to be in the mid carina, just so that we make sure we really crush it to the side.
Yeah, that's about here, right? Everybody happy?
Yeah, that looks good.
Okay. Yeah, Dr. Rab was my interventional attending at Emory. So here, so and sometimes the simulator, despite the fact it's obviously there's some real world physics going on here that's not quite right, but that's us going up to 35. Clearly the balloon was looking quite interesting. So yeah, Dr. Rab trained me. So he's probably gonna standing there saying, "Kwan, stop doing that."
No, it's okay.
But up here, all right. So 14 atmospheres. All right, good. And then it tells us that 10 minutes of floor time has elapsed. So we're going to tell it to not bother us with that. And I'm putting the balloon back here. Okay, and then here, I'm going to see whether I can wire with this.
So let's talk about rewiring. I mean, what kind of strategies should people have success with, and what kind of wires in trying to get to the diagonal side? Because this is the tough part. This is a tough part. You could do very well if you've done a good pot. You may just fly in, okay? Yeah. And what kind of curve do you want to give to a wire? So what I do personally is I take 3 different wire choices. I can still use a run through. Yeah. My next choice is pot at 50, and then more recently I've been using the Mongo wire, but always give a double curve to it. Try to make a, what do you call make it coiled overs and push it distally through the LED stent, then pull back and try to re-engage the diagonal.
Yeah, clearly, Dr. Rab, you trained me well because that seemed to go very easily. So we have rewired here, you know, and yeah, once again, proximal cell crossing, right? At this point, usually you have to send a small balloon down because you're crossing stent struts to open it. Within the simulation environment, it seems to be okay for us to send regular NC balloons, but you know, all of us who have done this, the recrossing sections tend to sometimes be the most difficult parts. When you are struggling, I use the Sapphire 2 or the Takeru. You know, you have to be familiar with those balloons, and if you're going to do this often, you really should have those balloons in your shelf.
The other balloon that can work in that scenario, Kwan, is a glider balloon.
Yeah.
Because it has a unique bevel tip that you can actually spin it and rotate it as it gets off the struts as well. But yeah, I agree with the other two balloon choices as well. Even though people say that, oh yeah, you know, I can put a 2.5 NC balloon directly through the stent struts. I agree with you that that's not what happens in real life practice, unfortunately. And you know, we have spent a lot of time trying to cross in between the stent struts.
Yeah, that tends to be the worst part of bifurcation stenting, the recrossing.
Indeed.
And yeah, without those balloons on your shelf, you know, I think about 20% or 10%, 20% of the time you will fail and just simply be unable to recross ever again.
Yep.
And that's clearly the situation you want to avoid, because failure to perform final kissing in current outcome definitions is considered a procedural failure, right? For a 2-stent strategy. Okay,
Agreed.
so we have a 3.0 and a 2.5 here. And then we will let Dr. Sendrowski, and I'm going to position the balloons. Like I said before, we have skipped one of the steps in the sense that this balloon, okay, this is a 3.0 here, and then a 2.5 coming across. You know, this happens quite easily in this scenario. And in real life, you know, like you said before, it can be quite a bit more difficult.
So you want to tell the audience how you're sizing the balloons now?
Yeah, so now we are sizing to the target vessels distal to the bifurcation. Okay. So just now 2.75, we decided to go 3.0. So we'll do 3.0 on this side, on the LED side, and a 2.5/12, and they're both non-compliant, size 1:1. And then after we do this, you know, then you size, do a repot, which is once again a modification of the original DK crush. But the current EBC, the latest update does recommend it, and I'm sure the American Bifurcation Club has the same opinion. Am I right?
Yeah.
Yeah, I would endorse the pot kiss pot. Yes, indeed. What do you think, Basir?
Absolutely.
Yeah.
And then Dr. Pineda and Dr. Sendrowski are here going to perform the thing with the floral petals on there. And then each one will go up, you know, do the one at a time. Go ahead, you go first. Yeah. One at a time, and then.
What is the pressure you're going to aim for now?
Yeah, we're going to aim for like 15, 16, 17, 18.
So, Perwaiz, how do you deal with the kissing portion? Do you go up one at a time, or do you just go up both at the same time to kissing pressure, or do you go up one to higher pressure and then down, then the other one up to higher pressure, down, then both together? How do you tend to do that, Perwaiz?
I try to do them together at the same time, simultaneous kissing. The problem is there are times that you can get some slippage of the balloon depending on the length of the balloon you choose or the angulation of the kiss. So there are always variables that are beyond your control. So I think for the most part we try to do simultaneous, but of course there are times when you have to do one versus the other first.
Okay, yeah, that's great. So now we are both at simultaneous 12, and they're going to kind of simultaneously get married. Yeah. Okay, great. All right, it's close to the half hour to move on to the next case. So I was just going to show you the post. So for this case, we then do a final pot, and then we have a post PCI IVUS, which I've actually saved on the video. I'm going to jump back here and reshare this just to show you what the post PCI IVUS in the simulation environment looks like as well. Obviously, the goal with the post pot is to obtain resphericity of the whole thing and to clearly ensure a complete apposition, etc.
Absolutely.
So this is the small balloon. In this case, not doing live, just in the interest of time. We did do a small balloon pre-dilatation. This was the second kiss. And then the inflation here. And I'm going to jump to that. And this is the final part. Okay. And then the final angiogram, which we did see earlier as well here. That's what it looked like. And then final
that's a great case.
We're going back to the beginning.
After you look at the final IVUS, you can also tell us some of the complications that you can simulate, so that fellows who are learning can kind of think about what are the kind of complications that can happen that we can simulate for them.
Yeah. So the simulator.
Wait a second. I think screen share is taking back to the beginning of the case. This case. So.
No. This is not the beginning. This is this was the final angiogram. Can you see that? This is after the DK, and this is the IVUS.
Yeah, I'm able to see it, Kwan.
Okay.
Okay. And then this was the final IVUS. I'm going to play it here. Yeah, so that's a great question, Gautam. Obviously we wanted to build some unpredictability into the system, and the ability for a proctor to remotely cause complications, to allow the learners to respond to that. The system can do no reflow. It can do stent dissections, and then thrombus formation at the site, and you can determine exactly which of the sites you want this to happen at.
That's great. That's great.
Yeah. So good apposition, etc. The physics around the polygon of confluence, there's some strangeness about this, but I think it's good enough for the group, hopefully. So yeah, I think it's an exciting technology. There's lots of there are CTO modules built into it. There's calcified lesions. There's bypass cases, etc. You can go radial, right radial, left radial approach, right femoral, left femoral. I think the real challenge here is how do you develop a curriculum and how do you really integrate this into fellowship training across the country. The price point is significant. And the way a lot of us have who are interested in the field have been able to fund this is through philanthropy and donations. But like how exactly do you do this? And this is pretty much the work that I've been trying to dedicate my time to understand how we integrate simulation as part of routine fellowship training. And it's obviously best for unusual cases that you don't do often, that are complex, that require many steps.
But this is a step in the right direction, I think. Certainly in training, we at one point, I think in my career, I've seen multiple models like this come over to my institution for people to train, but it never gained traction. Maybe the time is again to sort of revive it, at least for complicated corneal anatomy, demonstrate at least as close to normal what approaches we take, so people can practice the steps at least before they can do a real case.
Yeah.
Pervaiz, what do you think?
Yeah, I totally agree. You hit the nail on the head. I think there's so many different fields outside of medicine that do a lot of simulations as their part of their normal training. We all know pilots do this, in terms of crash training, et cetera. I think it's important, as Gautam mentioned and you mentioned, is that we're able to obviously simulate a case, which is great, but the complications are just as important, because fortunately we don't see that many complications today that we did probably 20, 30 years ago. So the guys who did this 20, 30 years ago are very adept at dealing with complications. We just don't see them as much, so the fellows don't see them as much, and so it's important for them to get that training and what to do. And it's just like anything else, it's muscle memory, it's hand memory. The more you do it, the better you get at it, so simulation definitely helps.
But one thing I'll definitely tell you about DK crush, if you don't follow the steps correctly, particularly in a situation like left main, you can have left main thrombosis, which can be a fatality, okay? So when you have a two-stent strategy in a very critical location, okay, the downside is if you don't do it right, if the stent struts protruding out, they've not been crushed, there's not optimal dilatation, you run the risk of stent thrombosis, okay? And then you've got to be wary of that, very wary of that. So with that, thank you so much, Kwan. That was really super, and Gautam for taking this time to walk us through this. So we'll move on to Babur's case presentation, which Perwaiz Meraj will moderate and we'll chip in. And thank you, Perwaiz, for joining us as well. Thank you, Kwan. Thank you so much.
Thanks for having me. As I'm getting my slides up here, I think it's important for the fellows to know that, these simulators are usually at the major meetings, and when you're hanging out, it's nice to go down and spend half an hour practicing a little bit. I think it's a really nice tool. So I'm going to be.
I think for large institutions or large training programs, there has to be institutional commitment to doing this.
Sure.
And these things have come to facilities, just hung out as a trial design, but then the institution have not invested in it. But this looks pretty cool actually today. So
yeah. So I'm going to be talking about a bifurcation case, and I'm curious to see what everybody would do. I always try to pick cases that, I may not have done everything in the most perfect manner. So let me see what everybody thinks. So this is a 76-year-old gentleman. He has hyperlipidemia, hypertension, diabetes, end-stage renal disease. He presents to our community program in the suburbs with an NSTEMI, rising troponin, is having chest pain, has early cardiogenic shock. His first lactate is 5. He has a TVP for complete heart block with a junctional escape. He has an intra-aortic balloon pump place. He has this coronary anatomy that you can see, disease and heavy calcification. I know that it looks as if it's maybe thrombus in the right coronary here, but you'll have to trust me that it's eccentric calcification, as well as later on finding out that he has an EF of 30% and moderate to severe AS, and unfortunately originally was accepted by surgery, but then 24 hours later was declined for surgery. So this is we did not plan this, but I personally think the model that we just did kind of mimics this Medina 111 bifurcation within the LAD and diagonal. You can also see in the LAO caudal shot the calcification that's noted within the proximal LAD. And why don't I open it up just quickly for the panel, maybe one by one. What's your strategy in this case? And maybe Perwaiz, you can start.
All right, so sounds like a really simple case. I think it's first year attending type stuff, so no problem. I think you have pretty much thrown the kitchen sink into this case, which is nice. You have hemodynamic issues, you have angiographic and calcific issues, and you got a bifurcation on top of it. So I think if you're going to look at just that LAD diag bifurcation, I think you're going to have to do some sort of atherectomy to be able to get through. If it was me, I'd probably end up going down I'd probably do the diag first, just because it probably won't impact the LAD, wire the LAD, and then, I'd lose my wire down the diag and then just go down the LAD and atherectomize the LAD. What you use doesn't really matter, but I think I'd support the case for sure with an Impella and probably go to town. So I'm curious to see what my colleagues have to say. So Gautam?
Hey, Perwaiz, yeah, finally I'm back. This is a tough case. Maybe I missed it. I didn't hear you tell me the gradient, Basir, on the aortic valve.
Off the top of my head, I don't remember it, but it's moderate to severe.
Okay, got you. I hope that that's not going to be a huge problem for the Impella. And, we're able to get the Impella across. If we can get the Impella across, I think it'll be fine. I agree with Perwaiz. I think we need to, what I would do is I'd wire the diag first, rotor the diag, and then pull the wire back, wire the LAD, rotor the LAD, and then address the bifurcation. Looking at this angle, it's probably favorable for a DK crush, but we'll have to see how it goes. Obviously, it's a difficult lesion, tough case.
Sounds good. I think that gives a lot of opinions. I think that makes it, you guys both committed to rotablation. Would you do something different with either using orbital atherectomy, or now that we have shockwave available?
Sure. I would feel comfortable doing this with orbital atherectomy. I think that would be fine. I would feel very comfortable with doing this with orbital atherectomy. I have used shockwave for a few cases. I'm not totally confident it will cross into that diag because it's pretty tight. You may have to do some kind of rotor shock, or I don't know if anyone has done orbital shock, but you may have to do something like that if you want to have a shockwave only strategy. But I think orbital will work fine too.
Prior to committing, would anyone do intravascular imaging to understand the calcium extent and distribution and etc. as well? I know it's going to be a little hard to deliver an IVUS probably past any.
I don't think it's going to cross, Kwan.
Yeah, I know. It probably wouldn't cross, but it'd be worth trying anyway. I mean, you got nothing to lose, right? You just slide it down. And also, the right has significant lesions too. Would you address the right first and then take on the more complex lesion in the LE diagonal? Obviously there are questions about renal function, all that kind of stuff that we don't have right now. But the right looks like a lower hanging fruit. It's very anterior takeoff, so you probably need a good AL1 long reach support guide. But I always find that if you get as much easy revascularization done before you turn over to the much more complex thing, it gives yourself a larger safety margin.
I think that's a really good, group of opinions, and I think that makes a lot of sense. And so, what ended up happening was that this patient actually stabilized well with the balloon pump and TVP, and was waiting for surgery, and then had recurrent symptoms, a little bit, worsening of his shock after kind of getting a little bit better with a little bit of a rise back in his lactate, despite getting dialysis, and then ultimately over a weekend, I ultimately ended up taking him to the cath lab. And so I did what you guys suggested here, kind of. I started with rotational atherectomy of the LAD. I used 1.5 burr. I personally did not do rotational atherectomy into the LAD. I started with a balloon. I also did not feel in either of these scenarios that I was going to be able to take down the volcano IVUS. I have not had good luck getting it down into this level of disease. And what you can see here is I wanted to try to be as transparent as possible. I want to show you every balloon inflation to as highest standards as I can do or was able to obtain. So we were able to use a 3020 balloon into the diagonal, as you can see. Then I used a 2.5 balloon in the LAD and slowly climbed my way back up. The 3.0 balloon that I used in the diagonal, I did dilate the proximal LAD with that as well. And then I IVUSed into the LAD to be able to start, all right? And my strategy was to use either, which is my typical strategy, is to either use a mini crush or a DK crush, depending on what I see, especially for how diseased this diagonal was. So what we ended up doing here now is then, you see that my balloon expanded well. I imaged into the diagonal, which was a 3.0 balloon, or excuse me, a 3 millimeter vessel. And I sized 1:1 here with a 3.0 by 20 stent. Then I crushed with a 3.0 balloon. Now the proximal diameter right before the bifurcation is around 3.5. The distal LAD where our stent was around 2.5, and the proximal LAD is around a 4.0. And so I crushed actually with a 3.0, whereas I do typically crush, 1:1, and with a 3.5 balloon, I did not do that in this case. I did, do it as a mini crush. So after I finished crushing, a DK crush, I went back, I did my kiss, and then I brought down my proximal stent that you can see here. And so now I have a 2.5 by 38 stent. And then I use a 3.0 balloon proximally to make sure that this is well expanded. And then I continue to use that 3.0 balloon on its way back. So then ultimately what I do is I take some pictures, make sure I have an idea of exactly what's going on in the proximal vessel. And I sized with a 3.5 stent. And after that stent, I took a quick picture just to make sure things were okay, and they were. Then I re-IVUSed into the LAD. And this is that IVUS run that's playing on your right-hand side. So it's a long run. I'll let you play it. I didn't want to hide anything here. So you can see that there's still a little bit of area of under expansion, both in the proximal segment and right at that bifurcation. And, I went back to 1-to-1 sizing with a quarter millimeter higher size than I had previously done, and I went to 18 atmospheres on every balloon inflation. I tend not to use 20 because it's a Xi'an blue and it can kind of get stuck onto the wire. And so I went proximally back to distally to proximally. And then I went towards the bifurcation, similar to what we just talked about. I did a 1-to-1 size initially with the diagonal, then high pressure within the LAD, and then a kiss. And what I didn't show was the pot. And then I did final angiograms. And this is what it shows. So what do you guys think about the results so far?
I think it looks fantastic. A quick question I wanted to ask, which was kind of might be irrelevant, but was this a single access or did you have a separate access?
I actually had separate access. He originally came in with the balloon pump, and I tend not to exchange a balloon pump sheath for an impella sheath because it's not my access. So I just worry a little bit more about it. So this was a bifemoral case with the impella, I believe, on the left side and an 8 French femoral access with a 45 centimeter bright tip sheath on the right side.
Yeah, I mean, it looks like a beautiful result here. And, I would have thought this is a winner given the complexities of this case. This looks like a winner.
All right, so I actually ended here too, and the patient did very well. I didn't show this, but I did treat the RCA as the first step of the procedure. He had end-stage renal disease, so we didn't have to worry as much about dye. He was supported with impella, and I didn't worry about this obtuse marginal CTO. And I thought he would do actually very well here. But the story goes on. And this is what happens 9 months later. And now I'm really curious to what everyone would do. And maybe we can take a few minutes and go one by one as to what people would do here.
So just for the sake, it looks like you restenosed, looks like he restenosed, but pretty much at the bifurcation, but mostly in the diag, but right at that turn with that calcific nodule that didn't look like it wanted to give on your balloons in the first angio is sitting right there. So Tanveer, we haven't heard from you. So Tanveer, what's your thought on why this happened?
I'm quietly moderating, but anyway, I think that the calcium was not totally expanded at that bifurcation, putting the LAD. So if there's this calcium, it's like a napkin ring all around, where the diagonal takes off. So I think, I mean, you went to pretty high pressures on the bifurcation, didn't you, Barbara, the first time around, and the LAD before you implanted the stent, right? So if I remember you saying that after rota you dilated pretty aggressively.
Yeah, absolutely. I typically even go, to 22, 24 atmospheres, particularly within the bifurcation segments in this area. But I agree with you. I mean, this is a 1.5 burr, right? And the IVUS demonstrated that there was actually a break in the calcium. All right. Mm-hmm. But there was a single break.
Correct.
And whether that single break is enough or not, I'm not sure. And, we have, a lot of experience with atherectomy. We do it, all different kinds, just as everyone on the panel does. And, this case made me really wonder, would it have been better if I actually used an orbital atherectomy and actually sat on the lesion for a longer period of time, as opposed to just kind of creating that break, which, really saves us probably at least over 90% of our cases.
Yeah, it's good. Sorry, go ahead.
No, sorry. Yeah, it would be kind of interesting as well, and I hate to sound like a broken record, but to also do some intravascular imaging, especially OCT here, because one of the questions that I think that will come up is the ISR inside the stent, or is it external to the stent with the calcium? And this calcified nodule is literally pushing back into the stent. Because clearly the one that's behind the stent, there are no instant options, and intravascular lithotripsy is probably really your only or your primary, besides laser bombing it. While if it's internal ISR, that changes things quite a bit. And what that internal ISR is composed of, it's hard to imagine that internal ISR could calcify at this rate with new atherosclerosis, but it's probably external pushing, but it'd be nice to see that.
So what about OCT at this stage, Dr. Basir?
Yeah, so we actually don't have OCT. We are an IVUS lab, and so I only have access to IVUS.
Okay, so maybe is there a way to get some IVUS images of this and see what our options are so that we can kind of understand what's going on? It's a difficult scenario. You now have stent there as well at that bifurcation. That kind of complicates things, but IVL is a viable option. At least for the last month or so, it's been a viable option in the United States for this.
So you're thinking about both limbs, Gautam, or just the LAD?
I am thinking of probably IVL of both limbs.
Perwaiz or?
Non-kissing, separate
Yeah.
IVL of both limbs.
Right. So I think I'm sure all of us have experience with IVL right now, and I think it is the newest hottest thing on the block. The issue with IVL in stent restenosis or in stent calcific nodules is that it's not quite as effective as it would have been at the beginning without the stent there. There is definitely an impact of the stent sitting there with IVL. This decreases the efficiency of it. We were doing a lot of off-label IVL using the peripheral balloons before the approval of the coronary balloons. And so I can tell you that it just, in scenarios like this, it tends to not be very effective unless and until you can get a good concentrated blow to that area. And so to Babar's point, I think you're 100% correct. I think that what concerned me about the original IVUS imaging is that, and it looks like this in a lot of these dialysis patients that we take care of as well, is that ring of calcium in the vessel sometimes fractures just once or twice, but it doesn't look like it got really cracked nicely. And so that nodular expansion just doesn't occur. And those are the cases that tend to restenose. At least I noticed that happens. Not 100% of the time, but they do when it does happen like that. It doesn't really work. So if it was me, I'd image this. I'd probably use IVL as a bailout and see. Hopefully, we get some benefit from it. You could try laser bombing it, but I don't know if a laser bomb is going to be that effective in the amount of calcium if it is that calcium behind the vessel.
I think these are all fantastic ideas. So, we published a nice series on using actually orbital atherectomy, particularly at high speed, to be able to try to kind of alter these heavily calcified lesions, particularly, in the setting of in-stent restenosis. But now that we have IVL, I think it's a much safer option. And so, I did talk to a surgeon. I asked them if he would change his mind. There was no minds to be changed. And so then we went on to what we talked about. So I employed the strategy that you all did. And just, the distal reference of this vessel is 2.5 in the LAD, 3.5 at the level of the bifurcation in the LAD, 4.0 proximally, and then in the diagonal, it's 3.0. So cost is a big issue with IVL. Are you going to use 2 balloons, 1 balloon, and what size are you guys going to pick? I think, all of us don't have a lot of experience with it, so I thought it'd be good to digress into this just a little bit.
That's a great point. I'm curious, does anyone have any experience in what's their take on the sizing of the IVL balloon? And obviously we all agree, I think our cath labs would be very much happier if we only use 1 versus 2.
You need to do 1-to-1 sizing, but you have 80 pulses available. So I don't know if splitting the 2 will work, but I have a feeling you'll need more concentrated pulses in the LAD, okay, than the diagonal. So that's my concern.
Sorry, I think Dr. Rab, this is a very difficult scenario, like what Perwaiz and you have also pointed out. What I would probably do is to take a 2.5 balloon shockwave and really treat that diag with maybe, if you have 80 pulses, probably put 20 in there, and I'll put the other 60 in the LAD and pray for the best.
This is fantastic. I mean, this is the kind of ideas that we wanted. So I ended up using a 3.5. So I went the other direction and went half a size up. And because we're only going to 4 to 6 atmosphere. Right. And this is the LAD that's there. And I did the same as what everyone said. So I actually did 60 pulses here because I really wanted to make sure that I got a good response. And then I used, I originally did 40 here. Then I did 20 within the proximal segment. And then my plan was to go back and do proximally in the diagonal. But this is a bulky balloon. And once it is used, it is even harder to actually get it into that branch. So it would not go into the diagonal, despite me already having kissed this area in my pre-step. And so, luckily I got a second balloon and it went okay. So what you can see here is that after we got done, sorry, I'm having a...
Just to clarify, you used 2 shockwave balloons, is that it?
I did. So I used a 3.5. They're all 12 millimeters, as you know. And so I did originally 40 pulses in the LAD, 20 pulses in the proximal LAD. And then as I was delivering it to the diagonal, I wasn't able to do that. So then I did another 60 pulses in the 40 pulses in the diagonal, and then went back and did 40 more pulses within the proximal LAD. And so ultimately, as you can see here, I got reasonable balloon expansion. This was the same level of balloon expansion I had gotten previously as well. I did the same technique again, a balloon into the diagonal, balloon into the LAD with a final kiss. And then I potted my way out with a 4 millimeter balloon as well. And this is my final angiogram. And you can see that there's, reasonable results, but there's still that touch. If you look closely within the ostium of the diagonal and the ostium of the LAD right at the bifurcation, there's still this area. And it's an important point that Perwaiz brought up. If we had this IVL therapy a year ago in its coronary form, I think rotational atherectomy and then IVL would have been really a great way to have treated him. And then I think afterward, particularly within that bifurcation where there's overlapping stents, I don't know if you're going to get as great of an effect. Now, we did we did cutting balloons, really high pressure, 24 atmospheres with Wolverines. And ultimately, this was my final IVUS is still images. The distal reference you can see on the right-hand side. The bifurcation shows 2 circles in the middle shot. And then my left-hand side shows you the proximal segment here as well. So, I'm hoping that this gives him a reasonable and long-term result. But I'm not sure. 9 months later, I could be showing this again.
But what if it comes back? What do we do next?
So I'm actually going to bring him back also to do brachytherapy. So he is scheduled for that later next month. So I'm hoping that helps. But in-stent restenosis from calcified plaque, doesn't respond as well to brachy as just neointimal hyperplasia, as you know. And so my other option here is really to get a 4th surgical opinion. And if his AS continues to progress, maybe that would be an option.
So OUS, I think DEB would be a very viable option in this scenario. There was some questions to the panel on the Q&A that was asking about a DEB. Unfortunately, we don't have coronary DEBs that are available for us in this particular application. And this vessel is probably a little small to try and fit a peripheral DEB in there as well. I don't think I would really try and get away with that. Now, I had a question for the panel, and maybe we can run this one of the last couple of questions, which is, depending on the timeline after your first PCI and you're getting this, what happens to the drug and the polymer and all of that when you're doing shockwave? Any ideas, guys?
Yeah, so there's theoretical risk actually of disrupting the polymer, particularly immediately after a stent is. So if you put a stent, had regret that you didn't expand that stent, and then you use this IVL, there is at least a theoretical concern that occurs.
Yeah, it shouldn't shed the drug, but it'll certainly fracture the polymer, which will probably change the elution profile and elution time and decrease the efficacy. But compared to any of the other techniques, like rotoblading it or laser bombing it, I'm sure your drug and your polymer, everything just completely disintegrates under those circumstances. So I think it's probably the lesser of the evils. with regards to preservation of polymer and drug. But that's a great question. I haven't seen a paper on that yet. It'd be really interesting. But given that this is the American Bifurcation Club, is anyone aware, and I was just very curious about this, has anyone ever done kissing balloon IVL before? I haven't seen that. And, that will obviously be a very expensive, very guide intensive type of thing. And you probably want to do it on an animal before you did it in a human.
So there are published peripheral cases of IVL, in the iliac system simultaneously. But from a coronary standpoint, that's a very, very expensive proposition.
There are two questions very quickly. The first was, how do you decide which vessel to do atherectomy first and chance of losing the second branch? And the other question was, which vessel to balloon first post-atherectomy?
So I ultimately ended up doing rotational atherectomy only of the LAD. In hindsight, I definitely could have done it in the diagonal. I would have done it if the balloon had not expanded in my first ballooning, but I didn't not have to do that. And I'm sorry, what was the second question?
Second one, after atherectomy, which vessel would you balloon first?
Well, I think typically you still have sometimes difficulty getting your balloons down into your main vessel. I personally would probably just balloon into the LAD first and then into the diagonal. I don't know if it really does make a difference, though.
So time is up, guys, and thank you very much. This was really a good session with Kwan doing the simulation, and that was really very instructive, and Barbara showing us a really common problem bifurcation and a very interesting case. And we really don't have really great answers yet for calcified bifurcations like this, and what would the best strategy be, but you do the best you can. I think they're still evolving. But thank you very much, all of you, for participating in this great session. Thank you very much.
Thank you.
Thank you. Have a good night.
Good night.